Welcome to the deep dive. Today we're diving into something really significant for anyone facing chemotherapy, managing nausea and vomiting, often called CINV.
That's right. It might not be the first side effect people think of, but wow, it affects a huge number of patients.
Yeah, the figures are quite stark, aren't they? Up to 80% of people on chemo might experience it.
Exactly. And it's so much more than just feeling a bit off. If CINV isn't handled well, it can seriously disrupt things.
How so? What kind of disruptions are we talking about?
Well, it can make it really hard for people to stick to their treatment schedules. Their energy just vanishes, making everyday stuff tough, and their overall quality of life just plummets.
Right. And our sources really underscore that if it's poorly managed, it can lead to pretty serious physical problems, too.
Definitely. Things like dehydration, metabolic imbalances, even malnutrition and significant weight loss. Sometimes it gets bad enough that people need to be hospitalized.
So preventing it, or at least actively managing it, sounds absolutely crucial.
It really is. But here's the good news, and it's genuinely good news. We've actually learned a ton about what causes CINV.
Okay.
And that understanding has paved the way for some really effective targeted medications. We now have anti-nausea strategies that can prevent CINV in, believe it or not, 70 to 80% of cases.
Wow, 70 to 80%, that's huge. That must be a massive relief for so many patients.
It's a total game changer.
Okay, so let's get into the why. Why do some chemo drugs cause more nausea than others? It's not just random, is it?
No, not at all. The chances of getting nausea and how bad it gets, well, that depends on a few things, like the specific chemo drugs used, obviously the dose, how long the treatment goes for.
And patient factors too, I imagine.
Yes, and even individual patient risk factors. But the single biggest thing, according to the research, is what are called the immunogenicity of the chemo agent itself.
Immunogenicity? Sounds technical.
It just means basically how likely that specific drug is to cause vomiting, its inherent potential.
Okay, so it's about the drug's built-in risk. And our sources lay out some categories for this, right?
They do. There are 4 main levels of this emetic risk. First up, you've got the high risk category.
High risk. Sounds serious.
It is. These are drugs where if you don't use preventative meds, over 90% of patients are likely to experience emesis. That's almost everyone.
Over 90%. Wow. What kind of drugs fall into that?
Well, cisplatin is a classic example, especially known for delayed nausea. Combinations like anthracycline plus cyclophosphamide. Also, higher doses of certain drugs like cyclophosphamide over 1,500 mg/mR or doxorubicin over 60 mg/mR. There's actually quite a long list, including some oral meds too.
That really highlights why prevention is so key with those particular drugs. What's the next level down?
That would be the moderate emetic risk category. Here, the chance of emesis is somewhere between 30% and 90%.
Still pretty wide range, 30 to 90%.
It is. This group includes drugs like carboplatin at certain doses, cyclophosphamide below that 1,500 mg/mR threshold, irinotecan, oxaliplatin, again, a substantial list of both IV and oral agents in our sources.
And you mentioned dose before. Does that apply here too?
Absolutely. For some drugs like cyclophosphamide and doxorubicin we just mentioned, their risk level actually changes depending on the dose. A lower dose might be moderate risk, while a higher dose pushes it into the high risk category.
Right. So it's not just which drug, but how much. Okay, that makes sense. Let's go down another level.
Below moderate, we find the low emetic risk drugs. Here, the incidence is between 10 and 30%.
Okay, a noticeable drop. Examples.
Sure. Things like docetaxel, lower doses of cytarabine, etoposide, fluorosil, gemcitabine. Also, a specific type of doxorubicin called liposomal doxorubicin often falls here. And interestingly, some of the newer targeted therapies land in this category too.
10 to 30%. Still significant for those affected, but much less likely overall. In the final category.
That's the minimal emetic risk group. Here, fewer than 10% of patients are expected to experience emesis without preventative treatment.
Less than 10%. That's quite low.
It is. This includes agents like bleomycin, fludarabine, very low doses of methotrexate, and many of the monoclonal antibodies drugs ending in MAB often, and also many hormone therapies.
But even minimal risk doesn't mean zero risk for everyone, I suppose.
Exactly right. Even with these minimal risk drugs, some individuals might still feel nauseous. Everyone's body reacts a bit differently, you know.
So this whole classification system, high, moderate, low, minimal, it seems like the bedrock for figuring out how to manage CINV for each patient.
It absolutely is. That immunogenicity level of the specific chemo regimen is the #1 factor guiding doctors on which preventative or prophylactic anti-nausea meds to use.
And what if someone's getting multiple chemo drugs at once?
Good question. Generally, the overall risk for a combination regimen is based on the single drug in that mix that has the highest emetic risk. You aim for the strongest protection needed.
Okay, that makes sense. Protect against the worst-case scenario within that combo. So once the risk level is clear, what are the main types of medications used? Our sources mention several classes.
Yes, there are several key drug classes that are really effective. The first, and maybe the most familiar to many, are the 5-HT3 receptor antagonists.
Ah, yes, I think I've heard of those. Ondansetron, maybe?
Exactly. Ondansetron, grinisetron, dolestron, and a newer one called polonicetron. These drugs work by blocking serotonin.
Serotonin, the happy chemical.
Well, it does lots of things. In this case, it acts as a key signal for nausea and vomiting, both in the gut, the GI tract, and in a special part of the brain called the chemoreceptor trigger zone, or CTZ. So these drugs basically put up a roadblock for those I feel sick signals from serotonin.
Right, blocking the message. How effective are they?
They're real workhorses. Generally, they're similarly effective when used correctly. Polonicetron, though, being a newer generation, has a couple of advantages. It lasts longer in the body and binds more tightly to the receptor.
So potentially better for longer-lasting nausea.
Potentially, yes. Some guidelines suggest it might be particularly helpful for that delayed nausea, the kind that shows up a day or more after chemo, and also maybe in moderate risk situations if other drugs like dexamethasone or NK1 antagonists aren't being used.
Interesting. Are there other forms?
There's also an extended release injection of grinisetron that can be an option, usually given with dexamethasone, and for nausea caused by radiation therapy, specifically, grinisetron and ondansetron are often preferred just because we have more data for them in that setting.
Good to know there are nuances. What about side effects or how they're given?
Important point. Always use the lowest effective dose. And it's good that taking them by mouth or getting them IV usually works equally well. Common side effects can include things like headache, constipation, maybe some dizziness, sometimes temporary blips in liver enzymes.
Anything serious?
There can be some effects on the heart's electrical rhythm, these ECG changes, though it seems less common with polonicetron.
Okay, so that's the 5-HT3 antagonists blocking serotonin. What's the next major group?
The next key class is the NK1 receptor antagonists. These have names like aprepitant, fosaprepitant, which is basically a form of aprepitant given IV, and newer ones like rolapitant, or combination pills like nitupitant polonicetron, often called NEPA.
NK1. Sounds different. How do these work?
They target a different neurotransmitter pathway. They block something called substance P in the central nervous system, the brain and spinal cord. And this substance P pathway seems especially important in causing that delayed CINV.
Ah, the delayed nausea again. That sounds like it could be really miserable, lingering for days.
It absolutely can be. And these NK1 drugs have made a huge difference there.
How so?
Well, when you add an NK1 antagonist to a 5-HT3 antagonist and a corticosteroid, we'll get to those next, it significantly boosts the prevention of both the immediate acute nausea and that persistent delayed nausea.
So a 3-drug combo is often better than 2.
For moderate and especially high-risk chemo, yes. Clinical trials show that this triple therapy is generally more effective. Rolapitant, for instance, is specifically approved just for preventing delayed CINV.
That's really encouraging for managing that whole nausea experience. Any downsides with these NK1 drugs? Interactions, maybe?
Yes, that's a key point. Drug interactions. Aprepitant and nitupitant can interfere with an important liver enzyme called CYP3A4.
And that enzyme processes other drugs.
Exactly, including dexamethasone, a common corticosteroid. So often the dexamethasone dose needs to be lowered when it's used with aprepitant or nitupitant. Rolapitant affects a different enzyme, CYP2D6, so different potential interactions there.
So doctors really need to check all the patient's medications. What about side effects from the NK1 drugs themselves?
Common ones can include some dizziness, maybe loss of appetite, or diarrhea.
Okay, so 5-HT3s, NK1s, you mentioned corticosteroids. Let's talk about those. They seem to pop up everywhere in medicine.
They do. Corticosteroids like dexamethasone, which we just mentioned, and methylprednisolone are very important players in CINV management too.
How do they help with nausea? Is it clear?
The exact mechanism isn't perfectly understood, actually. It's thought they might work in a few ways, maybe changing how cell membranes work, reducing inflammation by blocking prostaglandins, or activating specific glucocorticoid receptors in the brain.
Okay. And how are they used for CINV? Alone or in combination?
They can be effective by themselves for chemo that has a low risk of causing nausea, but where they really shine is in combination therapy for moderate and high-risk chemo.
Ah. Part of that triple therapy you mentioned.
Exactly. Used alongside the 5-HT3 and NK1 antagonists, they help prevent both the immediate and the delayed CINV.
Are there side effects to worry about with steroids?
With the short-term use typically seen for CINV prevention, serious side effects are relatively infrequent. But, long-term steroid use does carry risks, though that's less relevant here. The main thing, again, is that potential interaction with drugs like aprepitant or nitupetant affecting the CYP3A4 enzyme, possibly requiring a dexamethasone dose adjustment.
Right, that interaction point keeps coming up. It seems these drug classes really work best together for higher risk situations. Are there other types of drugs involved?
Yes. There's another older class called D2 receptor antagonists. These block dopamine, another neurotransmitter, in that chemoreceptor trigger zone and the vomiting center of the brain.
Dopamine blockers. Any familiar names there?
Sure. Metoclopramide, prochlorperazine, promethazine, even antipsychotics like haloperidol and droperidol act on dopamine receptors. Some antihistamines like diphenhydramine also have some anti-nausea effects, maybe partially through this or other pathways.
I feel like these were maybe used more commonly before the 5-HT3s and NK1s came along.
That's generally true. Their use is a bit more selective now, mainly because they can cause side effects like extrapyramidal symptoms, those involuntary muscle movements or restlessness. Sedation and low blood pressure can also be issues.
So where do they fit in now?
They definitely still have a role. They can be useful in preventing nausea with some moderate risk chemo, particularly for treating breakthrough nausea and vomiting, the kind that happens despite the initial preventative meds.
Ah, okay. So if the first line doesn't quite cut it.
Exactly. Or in refractory cases where the serotonin blockers just aren't working well enough. And metoclopramide has that added benefit of helping to move food through the stomach, which can sometimes help with nausea too. It's a prokinetic effect.
So still valuable tools, just maybe not the first ones out of the box for high-risk prevention. Now, there's one more drug, olanzapine, that seems to be getting a lot of attention lately.
Yes, olanzapine. It's actually an atypical antipsychotic medication, but it's shown remarkable promise for CINV.
How does it work for nausea?
It's interesting because it hits multiple targets. It blocks several types of receptors, including serotonin receptors, both 5-HT2 and 5-HT3, and also dopamine receptors, kind of a multi-pronged attack.
And is it used for prevention or treatment?
Both. It's proving effective in preventing and treating both acute and delayed CINV. In fact, it's now often recommended as part of a 4-drug combo for high-risk chemotherapy.
4 drugs. So olanzapine plus the other 3 we talked about.
That's right. Olanzapine plus a 5-HT3 antagonist, an NK1 antagonist, and dexamethasone. That quad therapy is a very powerful option for high emetic risk chemo. It's also shown to be really good for treating breakthrough CINV when it occurs.
That sounds like a really strong approach for those most at risk. What about side effects with olanzapine?
The main things people report are drowsiness or fatigue and maybe a dry mouth, and it's usually recommended to avoid using it at the same time as other dopamine blockers, like the D2 antagonists we just discussed, because of a potential overlap in side effects like those extrapyramidal symptoms.
But overall, adding it seems safe and effective.
Generally, yes. The regimens, including olanzapine, seem well tolerated and offer significant benefit, often comparable to aprepitant-containing regimens for high-risk scenarios.
It really is impressive how many targeted options there are now. Okay, beyond these main drug classes, what about other specific situations like anticipatory nausea?
Right, anticipatory nausea and vomiting. That's a tricky one because it's more of a learned or conditioned response. Patients start feeling sick just from cues they associate with chemo, like the clinic smell or even just thinking about it.
That sounds awful. How do you prevent that?
Well, the absolute best prevention is getting really good control of the actual CINV, the acute and delayed types, right from the very first cycle. If you don't have a bad experience, you're less likely to develop the anticipation.
Makes sense. Anything else?
Behavioral approaches can help too. Things like systematic desensitization, where you gradually get used to the cues in a relaxed way. And sometimes anxiolytics, like chlorazepam or alprazolam, might be considered to reduce the anxiety component.
Okay. What about when the prevention doesn't work perfectly and someone gets sick anyway? That's breakthrough or refractory emesis, right?
Exactly. Breakthrough and refractory emesis. It happens, and it can be really tough. The usual approach for breakthrough is to add a medication from a different class than the ones used for prevention.
So mix it up.
Yeah. If they're on a 5-HT3 blocker, maybe add a D2 antagonist like prochlorperazine, or add or increase the steroid if possible. We mentioned olanzapine is actually superior to metoclopramide for breakthrough CINV in high-risk patients.
What about how often to take the breakthrough meds?
Sometimes, instead of waiting until you feel really sick, taking the breakthrough medication on a regular schedule for a day or two can work better. For refractory CINV, meaning it's really resistant to treatment, you might need a bigger shift.
Like changing the whole prevention plan.
Could be. Or stepping up therapy, maybe adding benzodiazepines for anxiety, or even considering cannabinoids like dronabinol or nabilone in specific situations. And monitoring nutrition becomes really critical then.
Sounds like it needs a very flexible, personalized approach. What about non-drug approaches? Any complementary therapies that help?
That's an area where the evidence is, well, a bit less solid according to our sources. Ginger comes up a lot. Some small studies suggest it might help some people with acute CINV, but larger reviews haven't found a really consistent benefit.
Anything else?
Acupuncture or acupressure point stimulation. One study found it comparable to ondansetron for acute CINV and may be helpful for delayed, but again, we need more high-quality research.
And things like relaxation or guided imagery.
Biopsychobehavioral interventions, yeah. Relaxation, imagery, hypnosis, even exercise have been looked at. The results are pretty mixed, though. So currently, the major international guidelines don't strongly recommend for or against these complementary therapies. They might help some individuals feel better, but they aren't a substitute for the proven medical treatments.
Right. Good keep in perspective. One last area mentioned is radiation-induced nausea and vomiting, RINV. Is that managed the same way?
Similar principles, but the risk depends heavily on where the radiation is aimed. Total body radiation, upper abdomen, craniospinal, those carry the highest risk.
And the treatment reflects that risk.
Yes. For high-risk RINV, prevention is usually a 5-HT3 antagonist plus dexamethasone. For moderate risk, often a 5-HT3 antagonist, maybe with or without dexamethasone. If nausea pops up with low or minimal risk radiation, rescue options include 5-HT3s, dexamethasone, or dopamine antagonists.
Any specifics?
Dexamethasone is often preferred if the radiation is targeting the brain. And if someone's getting chemo and radiation concurrently, you generally base the anti-nausea plan on whichever one poses the higher emetic risk.
Okay, treat for the bigger challenge. That makes sense.
Exactly. Cover your bases.
Well, this has been incredibly informative. We've really covered a lot of ground on CINV. It's so clear how significant this issue is, but also, frankly, how much progress has been made. It's quite hopeful.
It really is. I think the main takeaway is that by, properly assessing the risk based on the chemotherapy and then using these targeted antiemetic strategies, hitting those serotonin, substance P, and dopamine pathways, we can make a massive difference for patients.
And having multiple drug classes like the 5-HT3s, NK1s, steroids, olanzapine allows for that tailoring, right?
Yeah. Absolutely. We can build regimens based on the specific emetic risk level, and those newer agents, palonosetron, the NK1 family, olanzapine, they've really pushed the field forward in managing both acute and that troublesome delayed nausea.
And it sounds like things are still evolving, which is great.
Constantly. Staying up to date on the immunogenicity of new treatments and the latest guidelines is key for clinicians. And for patients, it's about being empowered by this knowledge.
Empowered to do what, exactly?
To proactively discuss CINV prevention and management with their healthcare team. It leads to better planning, better control of side effects, better adherence to treatment, and ultimately just better cancer care and quality of life.
Couldn't agree more. So the final thought for our listeners is perhaps don't underestimate CINV, but also know that there are effective strategies. Have that conversation with your doctor.
That's the perfect advice. Open communication is vital.
Thank you so much for walking us through all this today. It's been incredibly valuable.
My pleasure. It's an important topic.
And thank you all for joining us for this deep dive. We hope it's provided some useful insights. Until next time.